Someone visits their doctor with a mild headache that's almost certainly just tension or dehydration, based on every symptom they describe. The doctor listens carefully, agrees it's probably nothing serious, and then orders an MRI anyway, along with a panel of blood tests that seem to have little to do with the actual complaint. The patient leaves confused, wondering why a probably nothing headache just turned into several $100s of imaging and lab work. The doctor isn't being greedy, and they aren't necessarily wrong to be cautious either. In a meaningful number of cases, that extra testing has less to do with the patient's actual medical risk and more to do with a separate, parallel risk the doctor is managing at the exact same time, one that has nothing to do with headaches at all. It's an unsettling thing to realize sitting in that exam room, that the decision being made isn't purely about your own body at all, but is also quietly shaped by a completely different question running through the doctor's mind, one about how this exact moment might look later if something rare turned out to be true. Medical testing gets discussed publicly as if it should purely reflect clinical necessity. Order a test if and only if the result would meaningfully change how a patient gets treated, skip it otherwise. And for the vast majority of medical decision-making, that principle genuinely does guide practice. But according to research published in medical journals and surveys of practicing physicians conducted by organizations studying healthcare costs and physician behavior, a substantial share of doctors report ordering tests, imaging, or referrals they privately consider clinically unnecessary, specifically because of concern about potential malpractice liability if a rare, serious condition were later discovered and the doctor hadn't ruled it out through testing, a practice widely referred to in medical literature as defensive medicine. This gap between what a doctor privately believes is clinically necessary and what actually gets ordered matters enormously in aggregate. Since it means a meaningful share of national healthcare spending reflects a professional risk management calculation running silently alongside, and sometimes overriding, the purely diagnostic reasoning most patients assume is the only thing happening in that exam room. Let's start with the basic mechanics of how malpractice liability actually shapes a doctor's individual decision-making in the exam room, because the incentive structure operates somewhat differently from how most patients assume medical decisions get made. A doctor evaluating a patient with a common, low-risk symptom faces two different kinds of errors they could make. Ordering an unnecessary test costs money and time, but rarely results in serious professional consequences for the doctor personally. Failing to order a test that would have caught a rare but serious condition, even if the odds of that condition were genuinely very low, can result in a malpractice lawsuit if the misdiagnosis leads to patient harm, regardless of how statistically reasonable the original decision not to test appeared at the time. The technical process works like this. From the doctor's individual risk perspective, the asymmetry between these two possible errors, an unnecessary test with modest financial downside versus a missed rare diagnosis with potentially severe legal and professional downside, creates a rational individual incentive to test more than pure clinical probability alone would suggest, even when both the doctor and patient privately agree the test is unlikely to change anything. This is where an invisible legal and professional mechanism takes over, one that most patients never see explained during an actual appointment. Malpractice liability in most jurisdictions gets evaluated partly against the standard of what a reasonable physician would have done under similar circumstances, and demonstrating that appropriate testing was ordered and came back normal provides concrete, documented evidence of due diligence if a doctor's decision-making is ever legally scrutinized after the fact. A normal test result that confirms what the doctor already suspected clinically still serves a distinct, separate function. It becomes part of a permanent medical record demonstrating that the possibility of a rare but serious condition was actively considered and ruled out, rather than simply assumed away based on clinical judgment alone. This means the test can be simultaneously clinically almost certainly unnecessary from a pure diagnostic standpoint and professionally valuable from a liability documentation standpoint, two different functions bundled into the exact same medical order. There's a related invisible mechanism tied to how malpractice insurance premiums and institutional policies interact with individual physician behavior specifically. Hospitals and medical practices frequently maintain internal protocols, sometimes informal and sometimes explicitly written, recommending certain tests for specific symptom presentations, partly based on liability exposure patterns from prior lawsuits within that institution or specialty, not purely on the latest clinical evidence about diagnostic yield. A physician who deviates from an institution's standard testing protocol, even when their individual clinical judgment suggests it's unnecessary for a specific patient, takes on personal professional risk that the institution's own broader liability management policy was specifically designed to prevent, creating pressure toward the institutional default even in cases where an individual doctor's private clinical assessment differs. Two real-world patterns make this concrete. Multiple physician surveys published in medical journals have found that a majority of doctors across a range of specialties report practicing at least some degree of defensive medicine, with estimates of the resulting unnecessary healthcare spending attributable to this practice reaching into the tens of billions of dollars annually in the United States alone, according to various health economics research estimates. A second pattern shows up specifically in specialties with historically higher malpractice litigation rates, such as emergency medicine, obstetrics, and certain surgical specialties, where research has consistently found higher rates of defensive testing and referral patterns compared to specialties with historically lower litigation exposure, even when comparing patients presenting with clinically similar symptom profiles, suggesting the difference reflects liability environment more than underlying patient risk. This challenges the common assumption that every medical test ordered reflects a purely clinical judgment about what information would meaningfully improve a specific patient's care. In reality, a meaningful share of testing decisions incorporate a parallel, separate calculation about professional and legal risk management that exists independently of the specific patient's actual diagnostic needs. The friction point isn't that doctors are behaving unreasonably given the incentive structure they actually face. Ordering a defensively motivated test is often a rational individual response to a genuinely asymmetric risk environment. It's that patients rarely receive a clear explanation distinguishing this test is for your specific diagnosis from this test is part of managing a separate professional risk, which leaves patients confused about costs and testing volume that, from the doctor's actual decision-making perspective, made complete internal sense. Zoom out, and this same individual behavior shaped by liability exposure rather than pure task optimization pattern shows up in other professional fields facing similar asymmetric risk environments. Auditors and accountants have been over-documenting routine financial reviews, partly to protect against future liability if an audit is challenged, beyond what pure accounting standard alone would strictly require. Engineers and architects sometimes specify additional structural safety margins beyond strict code minimums specifically to protect against future liability exposure if a structure ever fails, even when the underlying engineering judgment suggests the code minimum would have been perfectly adequate for a specific project. In every one of these professions, a person's individual decision gets shaped not purely by the optimal outcome for the immediate task, but by an additional parallel calculation about how that decision would be judged after the fact if something rare and unexpected eventually went wrong. What ties all of these examples together isn't the specific profession involved, it's the presence of a legal or professional consequence that lands disproportionately harder on the rare error of omission than on the far more common cost of overcaution, which quietly nudges rational, well-meaning professionals toward doing somewhat more than a pure, first-principles analysis of the task alone would ever recommend. So the next time a doctor orders a test that seems disproportionate to a minor symptom, it's worth remembering what that decision actually represents within the broader system the doctor is operating inside. It probably isn't a sign of unnecessary caution or an attempt to generate extra billing. It's more likely a rational response to an asymmetric risk environment, where the downside of missing something rare vastly outweighs the downside of confirming something the doctor already suspected, a calculation happening in parallel with, and sometimes ahead of, the purely clinical judgment about what that specific patient actually needs.